So a warm welcome to everyone to this webinar, Collaborating Across Borders, Enabling Practical, Equitable Cancer Research with Ledidi Core. So this webinar is hosted as part of London Global Cancer Week. My name is Andreas, and I work as a Partnerships Director at Ledidi, and I will moderate the sessions today. And I'm very happy to be here with two incredible and inspiring clinicians, Dr. Olubukola Ayodele from the University Hospitals of Leicester, and Dr. Andreas Barat-Due from Oslo University Hospital. As you may know, London Global Cancer Week is an international platform that brings together global health leaders, researchers, policymakers, and advocates to share knowledge, foster collaboration, and accelerate progress towards improving cancer outcomes worldwide. And that's why in this session, we'll learn from Buki and Andreas' real-world examples and experiences for how Ledidi Core can be used to lower the barriers to international research collaboration and quality improvement projects. We have two keynotes today. First, Buki will open the session with her presentation called Enabling Global Collaboration Through Real-World Cancer Data. Then Andreas will share his experiences from a capacity building project between Oslo University Hospital and Malawi, focused on respirator use in intensive care with lessons learned for enabling collaboration between high and low resource countries. We will follow their sessions with a short panel discussion to double tap on some of the key messages from their keynotes. I will then do a short live demonstration of Ledidi Core to highlight key workflows and collaborative features in the system. And finally, if time permits, we'll have a short audience Q&A. So without any further ado, I will hand over to Buki for the first keynote presentation.
Thank you, Andreas. I'm just going to try and share my screen. Tell me if you can see my screen. All good?
Yeah, thumbs up.
Okay. So good afternoon, everyone. My name is Dr. Olubukola Ayodele. I'm a consultant medical oncologist and a fierce advocate for equity in cancer care. Thank you for joining this session during London Global Cancer Week. And today I'll share how the Ledidi platform has supported a large-scale collaboration across the UK and how tools like this can enhance global partnerships, because we do need high-quality real-world data and registries that would meaningfully strengthen cancer research and care. So why do we need better data systems? I think we know, working as clinicians, that cancer data across hospitals, regions, and countries are often siloed. There's so much fragmentation when it comes to spreadsheets, papers, and the system. And this fragmentation usually slows down research and limits our ability to compare outcomes, monitor equity, or improve services. We also know that data varies between sites and countries, and also collaboration across institutions can be slow and administratively heavy. But we do know that real-world data, what that just means is data collected in routine clinical practice, is now being recognized as essential for understanding how treatments work across broader, more diverse population than clinical trials alone can provide. Studies have shown that real-world evidence can capture long-term outcomes, represent older patients, those with comorbidities who are often excluded from clinical trials. As we do know, trials involve selected population, registries and cohort studies, which often don't reflect the actual patients we see day to day. And many teams across the world and even here in the UK lack the access to secure, scalable digital tools. But platforms like Ledidi can help overcome these challenges by creating a structured, harmonized data set across multiple centers. So what's Ledidi and why did we choose it? Well, Ledidi is a secure cloud-based platform designed for clinical research and registry development. It's built for clinicians, researchers, healthcare organizations. For clinicians, it provides a simple interface for recording clinical information without disrupting workflows. For researchers, it ensures that there's that consistency through what I call a predefined field, which would reduce the time spent in cleaning data. And then also for admin staff, it helps gain visibility into site participation and data completeness. There's also that enablement for data collection, real-time collaboration, and it can be designed for observational studies and prospective registries. And I think it's really important to emphasize on the practical features that matter, such as ease of onboarding, the uniform data fields, and the reliable data validation. So I'm going to talk a bit about some of the ways we've been able to use Ledidi or give you examples. One is the CONCISE study. So the CONCISE study is a real-world multi-center evaluation of adjuvant abemaciclib in high-risk hormone receptor positive HER2 negative early breast cancer. Using Ledidi, 21 trusts. Involving all 4 UK nations, so England, Scotland, Wales, and Northern Ireland, were able to collaborate rapidly. We had a data set, we collected data from over 1,000 patients, and a scale of that, something of that scale would have taken almost a year to put together, using conventional methods like spreadsheets or site-specific databases. But with Ledidi, we were able to do this in about 4 months. So we had a turnover of 4 months to put this together, and we're able to achieve that. So the CONCISE study itself explored treatment patterns, toxicity, treatment duration, and modification. So what did we learn from CONCISE? Well, we knew that this was a large, high-quality data set that needed to be delivered in a short time frame. We knew that this was national representation across clinical settings. So what Ledidi did for us was remove many of those barriers that we would typically see due to multi-site studies. So, for example, the difference between spreadsheet formats or inconsistent definitions or lengthy IT approval, because the platform is cloud-based. All we needed was the privacy agreement from the mother trust, which was University Hospitals of Leicester, and that covered everyone else that was involved in the project. So in terms of what we've also learned, we've used Ledidi in MDT practice. So our current metastatic breast cancer registry now goes on Ledidi. So this was a practice, or this was a service that I helped initiate in November last year. And what we've done is that it allows us to record clinical details in real time, follow patients over months and years. And this is helping our audit, because we know from a national cancer audit such as Naomi, it shows that we're not collecting data as appropriate, but using Ledidi in this MDT practice helps us to capture these key clinical variables for each patient, and allows us to follow outcome tracking. So I think for us who are clinicians but have research at the back of our mind, this is a real good platform for us. So, for example, my trainees, oncology trainees, if they want to do any project, they can get onto the platform and gain a robust longitudinal data set that we already have. So it's really good. And also we have evidence for service planning. So I think it's a real good thing to have, or that we found anyway. What about global potentials and equity consideration? I think that our approach can be scaled up, globally, which includes low and middle income settings where local research infrastructure may be limited. Because we know that Ledidi is cloud-based and lightweight, it can enable centers with limited IT capacity to participate in international registries. I think in terms of global diverse data sets, it can help improve equity and representation, addressing that long-standing gaps in cancer research and treatment, because it supports decentralization and centralized data models. And it also enables that diverse data collection. One of the ways I see in the future of using Ledidi is in rare cancers, because I think it's a solution for low incident disease that need a pool data set where traditional trials often underpower rare subtypes. And I think a global diverse data set would help improve that equity and representation. So what's the path towards harmonizing that global cancer research? I think international shared registries is really important. That cross-border real-world evidence program, better benchmarking and equity monitoring, and it just enhances that faster answers to clinical questions and encourage stronger global partnerships. So in summary, for us, Ledidi enabled the delivery of CONCISE across 21 trusts. It currently powers a living metastatic breast cancer registry in our practice. Its design supports global, harmonized, and real-world cancer research, and I think that the approach is scalable to LMICs, rare cancers, and global networks. So we'll take questions afterwards, but I will stop sharing.
Thank you so much for that, Buki. So next up, we got the presentation from Andreas, who will share his experience with running a project between Oslo University Hospital and Malawi, focused on respiratory use in the ICU. And I think he's got some practical lessons learned for enabling collaboration between high and low resource settings. So again, without further ado, take it away, Andreas.
Yes, Andrea, thank you so much. I suppose you need to actually to share my presentation, because
okay,
I'm connected on the hospital kind of part of the internet, so I don't have access to the presentation right now. So if you manage to do that, that would be perfect.
I will try my very best. Let's see if I'm able to get this into reading modus. That. Do you see this okay?
Yes, perfect. That's excellent. Thank you so much. So briefly, I'm going to present Oslo University Hospital's engagement in Malawi, which is about anesthesia and intensive care medicine capacity building in this country. And where also Ledidi has taken part for the past 2 years. Next, please. Malawi is a small African country in the southeastern part, but with a growing population now reaching more than 22 million. It's a poor country with a total expenditure on health, which is very low compared to at least Norway, which is one of the richest countries in the world. And the next slide also demonstrate, Andreas, please change, that this is underscored in this bubble diagram, where you find on the x-axis expected level of income, where on the y-axis you have expected lifespan, and you find Malawi in the low left quadrant, whereas UK and Norway is in the upper right quadrant. So it's just an illustration of the kind of difference in income and life expenses. So this is a low resource setting. Please, next. Throughout the years, it has been a kind of constant focus on infectious diseases, obviously because with good reasons, as infectious diseases in general have been and still are a huge challenge. However, in 2015, the Lancet Commission on Global Health published data based on empiric data from 2010 that 16.9 million people died due to lack of access to safe surgery and anesthesia. And this is more than 4 times compared to HIV, tuberculosis, and malaria combined. Next. So patients requiring surgical treatment will face multiple hurdles: delay in seeking care, delay in reaching care, and delay in receiving care. And if the patient reaches the hospital, this does not guarantee treatment, as many of the hospitals lack the proper infrastructure to provide emergency surgical care. Thus, easily treatable diseases may be disastrous. You can easily die due to lack of access of emergency surgery because of an inguinal hernia. So surgical services are needed, they are affordable, they are life-saving, and they promote economic growth. And we also know that surgical services require provision of safe anesthesia. Please, next, Andreas. Can I have the next slide, please?
Mm-hmm.
Thank you. No, back again. Sorry for that. So this is the background for our project. So in Malawi, anesthesia and intensive care services are poorly developed. They are insecure, and they suffer from shortage of skilled staff. Thus, our aim is to increase the number of educated and well-trained anesthetists responsible for anesthesia and intensive care management. And we do this by support and guide candidates in Malawi. So Norwegian consultant anesthesiologists stay in Malawi on a rotating base. We work bedside with the candidates, increasing practical skills, assess and give feedback. And we also provide weekly lectures. Economically, we support the candidates with stipends, and we also cover exam fees and college fees to the CANEXA, which is a pan-European college called the College of Anesthesiologists of East, Central, and Southern Africa. Now you can take next, Andreas. So this is the main entrance to the right of Queen Elizabeth Central Hospital, located in Blantyre, which is the second largest city in Malawi. It's a referral hospital, it's a large hospital, and just to mention a few numbers, the obstetrical department handle around 12,000 deliveries a year, I mean, and and around 3,000 C-sections are performed. To the left, you will find the outdoor area where most of the family members stay while their relatives are treated behind the walls. But already we can say that we have made some progress from 2018 to 2025, and the number of trainees have increased from 2 to 15 and senior consultants from 3 to 7. Next, Andreas. The ICU of these hospitals is far too small, with only 5 beds equipped with a mechanical ventilator. Medical judgment and correctly, prioritizing patients are therefore critical clinical decisions. It has been efforts on patient registries before. They have been created, but it has not endured for a very long time. They were often complex to maintain, especially since the data had to be extracted from paper-based patient files. So obviously an ICU registry could help us to track patient outcomes, to improve quality of care, help allocate resources and plan ICU services, and enhance surveillance for critical illness and intervention. And also a registry could help us in research and also benchmarking. But this at our stage now is probably more for the future. but this is obviously opportunities in this area. Please, next. So we wanted to make this registry very simple. We wanted to have some track on number of patients admitted to the ICU, some demographic data. We could choose in between diagnostic codes, but you have so many different diagnostic codes, so this was complicated and it was not registered in the proper way. So we decided to go for disease categories or patient categories. We want to have some information on the level of organ supportive care, on the amount of antimicrobial prescription, and whether it was positive microbial isolates, and of course survival as well. So we started very carefully 2.5 years ago, tracking data in Excel, and after a couple of months this data was transferred to the Ledidi platform. That was a very easy step. And as the Ledidi analysis tool is very easy to use, we could very soon arrange a quiz among the ICU nurses and doctors. For instance, ask the question, what is the mortality in our department? And that was a very interesting experience because they didn't have a clue. It was responses from 20% up to 60-70%. So please, next slide, Andreas. So this is the only table I can show. Is from our the report made in February, reflecting the period from 2023 to December 2024, and we have 600 patients, predominantly men, 56.1%. It's a young population, 36 years of age. They stayed 3.6 days at the ICU, and as much as 86.1% were mechanically ventilated, which is considerably higher compared to a normal ICU in Europe. Days on mechanical ventilation was not that long, but still 2.9 days is quite high. But as you see, the mortality rate is high, it's 36.4%, and this concerning the relatively young population age, this must be said to be very, very high. And they didn't know before, and suddenly we have some numbers, and we have these numbers also on different patient categories. So please, next. So what do they need? And as already been mentioned, this Ledidi platform is so easy. They need a smartphone. This is a low resource setting. They need bundles for internet connection. And the smartphone, they need to do the authentication, which I assume Andreas will go through after this, after a while. And they also need a laptop. And none of these ingredients, so to say, are expensive. And to be fair, they have managed good maintenance. The team manages, although the data is not fully complete. We have some whole, some patients not registered, but in general, the registration is going fine. It's person dependent, and they have not managed to establish a robust system, at least not enough. We have some future plans in the pipeline, and in Malawi they don't have personal identification numbers. They don't use that, they don't have it. But despite a widespread poverty in this country, most people or their relatives have access to a smartphone. We have therefore begun registering phone numbers, and as part of a broader project, we plan to conduct follow-up and assess long-term outcomes, which would be a phone call to the patients after 30 or 60 days. This has not been finalized, and we will also add a questionnaire related to quality of quality of life questionnaire. Yes, please. Next one. So establishing an ICU registry on the Ledidi platform has been very much easier than expected. It's the registry provides important information not previously available, which is very encouraging. Several interesting projects based on the registry are in the pipeline, and maintenance remains essential always when you have established a registry, and the fully robust system is still not in place, but in general they have managed very well. So I would say it has been kind of a success to implement this in Malawi, and of course, which already has been mentioned, they could enlarge the registry also to include other hospitals, not only in Malawi, but other in this consortium of CONEXA, which are those countries in the southeastern part. And they could start to collaborate on the ICU population in general, and they could also implement benchmarking in between. So it has, but research has not been fully set down, but we have some plans. So thank you so much.
Thank you, Andreas. Let me see. Just going to rearrange my screen share for a second. There we go. So thank you both for your presentations. And I think we can move on to like a short panel discussion and a couple of questions. Buki, you're a vocal advocate for reducing health inequalities, and you're also an active researcher. So perhaps you can start with this first question. How can collaborative research help reduce outcome disparities between high and low resource countries? And what role does data and shared evidence play in closing that gap?
That's a great question, Andreas. I think for me, collaboration helps to close that gap because it brings many perspectives into one shared data set. Because sometimes we feel that because we're in a high income country that we don't really have a lot to learn. But one thing I've seen from even just CONCISE is the difference in what we do even here in the UK. So even without going into a low medium income country versus high income country, even here in the UK where deprivation is different in different parts of the country, you could see differences in outcomes. You know, I purposely didn't present the data of CONCISE because it's just going to be presented for the first time in San Antonio. So I'm keeping the data very close to my chest, and that's why I didn't show that. But you can see the differences in different areas. So imagine if this was a multi-center global study. You imagine the difference we're going to see. So I think it's really important to bring that collaboration because it helps to close that gap. Also, what I foresee is that we're talking about real world data. We know that a lot of countries, which are low, medium income countries, were not involved in clinical trials that have used drugs such as this that we were looking at. It would be interesting to see how people actually respond to the drug in terms of toxicities and efficacy, because we don't have that. You know, that's where real world helps us that we don't have when it comes to clinical trials. So I think that closed the gap. We learn from each other. The high income country is learning, the low medium income countries are also learning. And I feel like Ledidi is such a platform that helps to leverage or put that equality there so that whatever data that you are getting, you can standardize it and you can see the difference on the dashboard. Well, that's what I think.
Andreas, anything to add to that?
Yeah, we as I said, we don't have put it so far to start research, but I mean, establishing this registry has revealed that the obstetrical patient population is really doing very bad at the ICU. So you could use the registry to address some key questions. Why is it so that people are ending up in the ICU so kind of on the really severe illness axis? So could we do some intervention before, during the C-section procedure? Is it happening during the night? I mean, they have so many C-sections. It's around in between 10 and 15 every 24 hours. and maybe 6 is going on from 6 o'clock in the afternoon to 6 o'clock in the morning. So it's completely dark, and they don't have access on blood so easily. So I mean, you have cardiac failure, cardiac arrests, and really severe situations. So they were a bit surprised about this kind of very high mortality rate they discovered. On the other side, they in a way knew this from before. It was covered in a kind of a gut feeling, but they didn't have the numbers. So I mean, the registry explore and dissect the data, so you can address where you want to put your effort. So in a way, yeah.
Yeah, exactly. I think, that shared data, it would expose the differences in care and just even highlight what works, and I think for research, it gives countries without that large research infrastructure to see evidence that they can use straight away. So I think it's brilliant to collaborate, and that would help level out disparities.
All right. So, Andreas, based on your experience, what are the most important enablers for an equitable partnership in this way, where both participants benefit and insights can flow both ways? I think it extends to what we're just talking about.
Yeah, it's a bit complicated to really answer that question. I think when it comes to implement Ledidi as a tool, I think they benefit on that. I knew the hospital because I've lived there. They personally know me as a person. But I also think that Ledidi is so easy to use. So I mean, I know from the hospital that another department, which I also know a little bit, I know some key persons in this, but they have not received any help from me at all. So they have been collaborating directly with the Ledidi in Oslo and had a good support from them, but they have actually implemented the registry themselves without any kind of collaborating work. So Ledidi itself as a firm could actually provide these services to these countries. So in a way, but when it comes to a project like this, I think to have a registration on patients is encouraging for all people who get involved, even though you will always, I don't think the registry itself make it more easy, but yeah, it make it easy in that way that you can address specific medical issues. It's concrete in a way. We need to focus on this instead of that, but to compare numbers from Norway with Malawi now would be completely unfair, but and not relevant. So, but for participants joining this project, it's absolutely nice to have a system working with and use as a kind of hypothesis generating data. Yes.
Okay, anything to add to that?
Well, I would say that it's a partnership. So for me, a few things make partnership equitable. So I feel like if you're going to start a project, you all have to have a shared purpose. So everybody's understanding what they're doing. For us, when we're doing CONCISE, everybody knew what the goal was, that we wanted to look for toxicities and efficacy. And because we had all of this data on a platform, we can continue to monitor these patients over time. So even when the juniors or the trainees change hands, we can still access the same data, and you can have newer people update this data. So I think it's really important. Also, I think balanced decision making. So for example, and what Andres was saying is that accessible technology. So for our metastatic registry, it's being done by admin. Like, it's very easy to use. Once you have the template that's on there, and you want to make sure that you have everything, and even you can always modify the template that you have. So it takes that barrier away that you would normally would have problems with a smaller or lower resource team. So everyone can contribute and benefit equally. So
Thank you. All right, final question. So more practical in nature. What advice would you give clinicians or researchers who want to start their own quality improvement or research initiative with partners in lower resource settings, especially something that touched on the topic of today around data sharing, governance? I really want to double tap on your point too, Andreas, around sustaining engagement. How do you keep people motivated? How do you keep people, there are incentives and cultural things you need to think about. Any practical tips for teams in terms of that, what they should think about and prepare for?
This is a very, very big question. I mean, to the governance and the maintenance and to keep the Malawian motivated, engaged in this, in a way, is difficult. And I think this is about a low resource setting, because what is it in for me is a question you would be confronted with. So it's not, I mean, even though we in our part of the world, research is mandatory in a way to survive in our system. It's we are obliged to do it. This is not the case there. So you need to feed them with some kind of it's something which is beneficial for them, and sometimes that is difficult to find. So you have key people there as well, and I think one way is to do projects. So we will start a project next year, but then you need to find what should they have back to do these phone calls to patients 30 or 60 days after. Do they receive more money, or what else do they benefit on? Because the science itself is not necessarily so important. So this is it's difficult to find some kind of motivating things which are lasting for a long time. So we have challenges, but you find these similar challenges in all these kind of projects, I think, in countries like Malawi and others. So it's complicated, but you need to work continuously with it. Yeah.
Thank you. Cookie?
Well, yes, I think because this is a digital platform, everyone gets nervous about patient safety. So I think it's really important from the beginning to agree on who can see the data, how it's going to be used, how the result is going to be shared, because I think that's usually, for example, places like the UK, you want to make sure that people's data is protected. So practically what we did was we already had a privacy shared agreement with UHL, which was the mothership, like I said, and we made sure right from the beginning that no recognizable information was put on Ledidi. So that was part of our protocol. We set that out for everyone that was participating. Because also we made sure that there was no so for example, when we're collecting things like we only collected months and age. We didn't do date, because once you put a date in, then that would automatically turn into identifiable, and you would then need a special how do I say, a special request from your trust that makes things complicated.
Yeah.
So I think it's understanding what you're allowed to put. So you can put things like the patient's NHS numbers and stuff online. Those things are really important. So what we in the protocol while we're building it, we explained everything as it should be, and we made sure that people checked with their local trust to make sure that it was okay. So what we did was that before it ever came onto Ledidi, they were given an alphanumeric number that is only known to the people in the trust. Also, in terms of people that add access, so with Ledidi, you can add people as collaborators and you can restrict the access that they had. So because I was the lead, I had access to everyone's data and I was able to see it all on the dashboard. But the people who were imputing from the trust had access to only their own data. So I think that's really reassuring for people that want to collaborate and make sure that their data is now seen by other people, except for the people that really matter. So I think that's important. I think it's important to plan regular check-ins just to make sure that communication stays strong, because I can tell you people can go quiet very quickly. But the beauty is that on the dashboard, you can see people that need support, people that are not doing enough. So you can push those people and say, you're just still, your numbers are still low or something, and it just motivates people. So I think these are practical things to learn. As long as all of that are put in your protocol for research. In terms of registry, I think for LMICs, Ledidi is a really good platform because a lot of this are struggling with registries. You go to these countries and you ask for simple data and it can be produced. But if you have Ledidi, you can real time impute what's happening in your hospital, wherever it is. You can also do national registries, so not only local registries, national registries, and it would be easy when you want to do audits. I think it's really important for audits and service usage to have registries, because that's how you best know how to support the people you're dealing with.
Yeah, I completely agree that the registry is the way to go. But I mean, you need to make the leaders of the hospitals to implement this as a routine. This is not you choose to do yourself. This is part of the routine. And to come to that stage, I mean, we have so much infrastructure with our health system and you have a huge history in UK and also quite a good history in Norway. So I mean, but they don't have anything in these countries. They are not used to do the registration. So, but it has to be something that is part of the routine work and obligatory for all doctors working. So, so you need to collaborate with the leaders in order to really make this happen and be something that could be on the national level. Yeah.
All right, I'll leave that as the final say on the panel discussion, and I'll segue into the demonstration part of our session today. So I'm just going to stop this screen sharing and I'll share another one. I've got a Ledidi here somewhere. There it is. So I'm already logged in, but as has been alluded to, it's accessed from a browser, so there's no local installations or anything needed to run Ledidi. Just go to app.ledidi.no and log in with your credentials. It is protected with MFA that you also talked about, Andreas. You need a smartphone and then two-factor authentication to get in here. That is very simple because much of the data that we collect here is sensitive information. We need to protect it thoroughly. So I'll run through a very quick whistle-stop tour, and hopefully we'll be able to show how do you set up a study, how do you collaborate on it, how do you get insights from your data, and how can you enable safe sharing across settings in various ways. So it'll be really fast. Hold on to your seats. So I'll start a new project here, and I'm going to import a spreadsheet that I've got. So I'm just going to call this one Global Cancer Project. You can give it a name and stuff like that. I'll just skip all that in the interest of time. I'll click continue. When you set up a new project, there's a couple of ways to do that. One is you can start entirely from scratch with a blank piece of paper, define the variables you want to collect, put them onto forms, and start your prospective data collection. Many people start, if they've got an existing spreadsheet, I think this is how you started with your MDT and so on, Bucky, then you can do an upload, and I'll take this through because we'll have a little bit more to play with in the short time span we've got. So I'll click continue here. I'm going to click browse to find one of my demo files. I'm going to go with a file I've got called oncology dataset with PID. So this is a very basic data set. It's all patient level information with some simple diagnostics and demographics and treatments and outcomes data. So what it's doing now, it's screening that file for us and having a look at what are the various variable names. Just you see those here. These were just the column headers for my spreadsheet. So my first column was the personal ID, the second one was date of birth, and so on. And then it's looked at each of the rows below to decide, okay, what is the data type here? So the personal ID has been recognized by our system as, okay, import that one as a text. I can also make it unique. For example, then our date of birth is recognized as a date, name as a text, and so on and so forth. So there's just one more down here I want to change. That's risk score. It's a numeric, but I just want to use it as a category for analysis purposes. But I think other than that, these are all correct. So I'm going to click continue. And now what it does, it builds a database based on the same data structure that we just created. So you see here we've got 117 entries. The names and the PIDs, that's just all ChatGPT generated. That's totally fine. It's for use for demo purposes. But I think actually the rest of the database is actually real data. So you'll see the information presented here for the first 10 patients. If I open one of the records, it'll give me kind of a plain vanilla ECRF. This is just based on the order that the variables appeared and how I defined them. So you see overall survival status, we had 2 options in the data set. That's what's presented here. So it is live, it's functional. You can update the data here. You can also see an entry history for this patient in terms of who created the record, who made any updates at what time. But basically, now the data is in. If you say that's your initial dump and you want to keep adding prospective information to this, you can either add them one by one by clicking new entry. That will bring you up, again, a plain vanilla form. There's a forms designer. I can show it really quickly later how to organize things. It's also possible to add more data sets. So if you've got submissions from various sites and you're using the same data structure, you can merge them. So either add more patients to the existing data set, or you can add, if let's say you've got blood test results or scans from some of these patients, then you can add them as new variables for the same patient and just link them back with the personal ID. So before we move on, I'll just spend a few minutes on the forms designer. It's all just drag and drop. So I'm just going to call this one registration form. I'll go in here. I'll add my first form. I'll give it a title, global cancer. Trying to spell things right. Registry, like that. So on the left-hand side, you see the various variables that were in the data set. You can either just drag and drop them, or you can click the little plus icon to just kind of add them one after another. They can be drag and dropped and kind of rearranged as you see fit. You also got form elements like subtitles and text and separators that allows you to build sections and things like that. There's obviously also the option to build dependencies. If you have conditional questions, depending on whether you're a male or female, for example, you can build that in. I won't spend time on it today. Patient information, yeah, and so on and so forth. Oops. Like static text and instructions and so on. Please remember to check it's correct. All right. Again, super fast, just drag and drop. You'll get a feel for it really quickly when you play around with it. I'll update this form. If I go back to one of my patients in the data set, you'll see that layout applied instantly. So now I apply that layout here. You can also have multiple forms. So you can also collect repeated measurements using series. Again, won't delve into that right now. Getting into some of the more interesting things, I guess, is jumping into the analysis section, where we've kind of cherry-picked a number of useful analysis. So simple statistics, descriptive statistics, data visualizations. that helps you get a little bit of insight into this. It's not a complete statistical package, but you get quite far on the way here. So let's look at categories first and count frequency. So how many males and females do we have? Simple stuff like that. And you can then start grouping also by other things. Never tried that. This is actually new. Anyways, you can represent that graphically in a few different ways. You can see how this is all interactive. So that's my distribution of males and females. Let's go to the Explore one, which gives you descriptive statistics for numerical values. So looking at age here, like what are my means and standard deviations and confidence intervals and so on. So these can be useful to build baseline tables and so on, like what's the median age and what's the overall survival time in this particular data set. You got that here. All the graphs and the tables can be exported, by the way, if you need to use them downstream for presentations or publication purposes. This is an oncology data set, so I'll just quickly introduce the Kaplan-Meier here as well to do the survival curve. So in this particular one, I've got overall survival time in days. Just looking for my overall survival status to get the right endpoint, and that should produce a graph. And then you can do grouping on various things, like let's say, okay, where's the primary lymph node? Node positive, node negative. Apply these little tick boxes here to do things like confidence intervals and log rank tests and so on. So especially for clinical registries and in prospective settings, it might be useful to save these as dashboards. So you don't have to redo the analysis every time because it always live queries the database and these are updated in real time. So I'm just going to call this one dashboard, and then going forward, you can just update it from here. And you can save the view here to get a little bit more of an aggregate view. Another really nice thing here is how you can do subgroup analysis by applying filters. So let's say you just want to look at females for this particular data set, and just apply that and everything is recalculated. So that can be done from any combination of, like, let's say hospitals or comorbidities or age groups or whatever the case might be. All right, I'll skip quickly ahead to talk a little bit about collaboration and permission settings next. So we've talked a lot about collaboration, and let's talk multi-site initially. So I'll just define a couple of groups. So let's say Hospital 1. I'll create that, and I'll create Hospital 2 as another group. Hospital 2. So let's say that I belong to Hospital 1. And then I'll invite my first collaborator. So I'll invite one of my colleagues, Lauren, like this, and you see I'm able to give her quite granular permissions. I can also define predefined roles, which I haven't done yet, but that's also possible to do. So for instance, she's supposed to just input ECRF data from her own site, and these were the permissions I would give her. If she's working as part of a group from her hospital, then they should work collaboratively on that site. If it's something that we actually want, okay, let's enable them to do benchmark analysis and compare their performance against everyone else's, then you can set analysis to include all data, but without seeing the granular data from the other sites. So I've got some examples lined up in terms of what that looks like on the receiving end. I'll take that next. You can also control whether or not they can export data from the data set. And this one is important. Can they see restricted variables? So each variable can be marked as restricted. So let's say in this data set that I imported before, you had their names, the dates of birth, and the personal identification number. Let's say we marked each of those as restricted. If we say yes, you can see them, then that basically implies this person is probably working clinically and overseeing the direct patient care and should be able to identify that patient and be privy to that information. Anyone with more of an aggregate research interest should have that disallowed, so they can only see the anonymized portion of the data set. So I'll click continue here, kind of move on really fast. Hospital 2, there we go. And then send that invitation across. So that will give her an invitation here that she has to accept, and then she gets access to this one. Now, you see we've got 4 projects lined up here, and they're the exact same project that we saw before, just with different permission settings on me. So here I've got full access. You can see I can do most of the things in the project that you saw before. The only thing I can't do here is invite other collaborators. I can see all the data, I can do all the analysis, and do all the setup. If I go to project number 2, I've still got full permissions, except the 3 first columns were marked as restricted. And you can see they're kind of cut off for me now. I can't see the date of birth and the PID. So I can now see an anonymized but still full data set. And I can do analysis on it and everything else. This third one, I've got the permission to only view my own data, but I can analyze all the data. So here I've added one patient into this database. But if I go into analysis, I think I've got a very simple dashboard lined up. You'll see I'm able to analyze all 117 other entries in this dataset, but without being exposed to that patient level information. And finally, in this one, I can only perform analysis. Again, the only thing I can do here is just, let's say, run some of these analysis. I'll just pop this one up there again. All right, so I'll stop my sharing because we're already 1 minute over time. I think that also means we don't have time for any audience questions, but I do appreciate everyone's time. I'm sorry we kicked off a few minutes late. And again, to my amazing speakers, thank you so much for being part of this, and I wish everyone a lovely rest of the day.
Thank you, Andreas.
Thank you, Bookie.